Thank you guys so much. I'm really excited to be here. Again, I'm Stacy Schuler from Methodist Hospital. I'm a breast health nurse navigator specializing in breast cancer, and one of our jobs, or part of our job, is to ensure that women get the care that they need in a timely manner. They don't have any barriers to care. They're making their appointments with the physicians. They have the financial needs that finances that they need, transportation, whatever it is that they need. I'm there to support them, sort of hold their hand as they go throughout their journey of the breast cancer treatment. Closer to my mouth. Thank you. Okay, well, again, thanks, Toyota. I must say that I do have a Yaris. I burned out the clutch twice. My husband took it away from me, but I hope to get it back soon. So I love my Yaris. So without any further ado, let's get started. What I'm going to do today is just a kind of a breast cancer 101. So I'm going to throw some microbiology at you, some definitions, and statistics. So let's get started. Cancer is a group of diseases that causes cell in the body to change and grow out of control. So basically, every single cell you have in your body has a purpose. And at some point in time, whether it's from the environment, it's genetic, it's biological, something may trigger these cells to grow out of control and not serve its original purpose. And this is where it has the potential to grow into cancer cells. Most types of cancers cells eventually form a lump or a mass called a tumor and are named after the body part where the tumor originates. So if a tumor is found in the breast, that's considered breast cancer. Oftentimes you may hear a woman that says they have breast cancer, but now it's moved to the lungs, so they say they now have lung cancer. That's not necessarily the case. It's a breast cancer that has metastasized to the lung or the bone or the brain. But the original cancer cell started in the breast and traveled to another part of the body and settled in the lung, therefore causing what's called metastases. Breast cancer begins in the breast tissue that is made up of glands for milk production, called lobules, and ducts that connect to the lobules to the nipple. The remainder of the breast is made up of fatty, connective, and lymphatic tissue. Breast cancer is typically detected either by early screening examination, before symptoms have developed, or after symptoms have developed when the woman feels the lump. Does anyone know what age should a woman start having a mammogram? The magic number is 40. Yes, thank you. The magic number is 40. But if there's a family history, any suspicious mammograms previously, absolutely, you follow your doctor's orders. Most masses seen on mammograms and most breast lumps turn out to be benign, which means non-cancerous, and they don't grow out of control or spread, which is not life-threatening. So about 80% of lumps that are found by women are non-cancerous. So that's a good statistic. When cancer is suspected, further microscopic analysis of breast tissue is necessary for a definitive diagnosis. The radiologist will perform a biopsy to obtain a tissue sample that is sent to pathology for analysis. So basically what they do is they'll mark where the tumor is. They will inject a hollow needle into the tumor and then shoot another needle into the hollow needle and pull out samples and send that off to pathology. And that's where it's analyzed to see if it is cancerous or non-cancerous. There are typically no symptoms when the tumor is small and most easily cured. It's very important for women to follow the recommended screening guidelines for detecting breast cancer at an early age. And I know that Cordy had put out some of these shower hangers. So for the women and men, you can take it home and hang it on your showers. And this is just a cue to do your monthly self-breast exam. And I know my mother-in-law, when she found her, she said it was like a pea size. And it just seemed to appear overnight, and all of a sudden it was there. She went in, and it was cancerous. So if you ever feel anything that's suspicious or swelling, anything like that, please make sure that you see your primary care physician or your gynecologist. When the tumor has grown, there you go, that's okay. When the tumor has grown to the point where it can be felt, the most common physical sign is a painless lump, like the pea-size lump my mother-in-law felt. Sometimes the breast cancer can spread to underarm lymph nodes and cause the lump or swelling even before the tumor can be felt. Lymph nodes, you've got them all under your armpit area. You have well over 20. And that's the first place that a cancerous cell, if it breaks off from the original tumor, will travel there and can get trapped. So that's one of the other places that your surgeon would want to be assessing, if their surgery is done, to ensure that it hasn't spread. So some less common signs and symptoms: breast pain or heaviness, changes to the breast such as swelling, thickening, dimpling, or redness to the breast, nipple abnormalities such as spontaneous discharge, especially if it's bloody, erosion or inversion or tenderness, an itchy, scaly sore that won't go away, and any persistent abnormality in the breast should be evaluated by the physician as soon as possible. So, and I'm sorry this isn't real clear, but this is what you're going to be looking for. On the upper left, any lump. And this is a very common spot where this is highlighted here to have breast cancer. Pulled in nipple, inverted, any dimpling. It almost looks like the skin of an orange peel, the dimpling. Any dripping, obviously. Redness or rash or any skin changes should be assessed by your physician. So let's talk about some facts. About 40% of diagnosed breast cancers are detected by women who feel a lump. So establishing a regular breast self-exam is very important. Excluding cancers of the skin, breast cancer is the most common cancer among U.S. women, accounting for 29% of newly diagnosed cancers. Men are generally at low risk for developing breast cancer. However, they should report any changes to their physician. What percentage of men do you think get breast cancer? Any ideas? 10? Lower? Less than 1% of men get breast cancer. But it does happen, so awareness is also really important for men. Okay? Breast cancer incidence and death rates generally increase with age. So 79% of newly diagnosed cases and 88% of breast cancer deaths occur in women 50 years or older. So who's 50 or older in here? Okay, we need to be aware, okay? So we're in that upper median, so just awareness is going to be really important. So during 2006 to 10, the median age was 61 years old. And that means 50% of women who developed breast cancer were 61 years of age or older. A woman living in the U.S. has a 12.3% chance of getting cancer, or a 1 in 8 chance. So look around, women. Every 8th woman has a chance of having breast cancer. And just raise a hand if anybody here knows somebody that has had breast cancer. Okay? And of those people, who is a family member? Okay, and if you want to share, has anyone here is a survivor of breast cancer? Congratulations, wow, we got two, congratulations. So yeah, it's that puts things in perspective when you see how many people are affected by breast cancer on a daily basis. So incidence rates are higher in non-Hispanic white women than African American women for most age groups. However, African American women have a higher incidence rate before age 80 and are more likely to die from the disease. And that's basically because of accessibility in health care. Incidence and death rates for breast cancer are lower among women of other racial and ethnic groups than non-Hispanic white and African women. So Asian Pacific or the Islander women are the lowest risk category. So let's talk about some of the risk factors. First-degree family history of breast cancer has a higher risk of developing the disease. Of those people that have had breast cancer, did you have a family history?
Found out later.
You found out later? Okay. So knowing your family history is going to be really important too if there are suspicious tumors or if you have a history of breast cancer. And if you have children too, your daughters are going to make sure they get tested at an early age. 5 to 10% of breast cancers can result from inherited mutations called the BRCA1 and 2. And everybody probably heard about Angelina Jolie, where she had what's called a prophylactic mastectomy, where she knew she was at a very high risk of having breast cancer because her mother was diagnosed with it and died. And so she opted to go ahead and have the bilateral mastectomy with reconstruction, just so she decreased her risk. And the BRCA1 and 2, it's on chromosomes 13 and 17, and it just shows that it's a mutation, that you're a carrier for that disease. And it can you can kind of predict a higher risk rate. And she was at an 80% lifetime risk of getting breast cancer. So that's why she chose to do it. So we have all these fabulous diagnostics available to us today that we didn't have years ago, which will help tremendously in determining what our plan of care will be. Benign breast conditions may be linked to breast cancer risks also. A lot of women have very dense breasts or their calcifications, very fibrous breasts. These need to be monitored very carefully. So you'll want to talk to your doctor about the frequency of the mammograms that they do. And they will do a baseline and compare them to previous mammograms. So this also is very, very important. Women with a history of breast cancer, I skipped one, are at an increased risk for developing second breast cancer, especially if you develop the cancer under 40 years of age. High breast density, we talked a little bit about that. Postmenopausal women with high levels of estrogen or testosterone have about twice the risk of developing it. So personal family history continued. Women who started menstruating earlier and went through menopause later have a slightly higher risk of breast cancer. Why do you think this is? It's because they have a higher lifetime exposure to estrogen. And estrogen is known as, it can be one of the causes and risk factors for getting cancer. So if you're starting your period earlier and ending later, all those extra years, you have more estrogen in the system and more exposure and higher risk factors. Younger age at first full-term pregnancy and a greater number of pregnancies decreases the risk of breast cancer over the long term. Again, then you're having more pregnancy, you're younger, you don't have that exposure of estrogen over the lifetime that you would if you didn't have children. Most studies suggest that breastfeeding for a year or more slightly reduces a woman's overall breast cancer risk. So lifestyle, let's talk about some of the factors. Recent use of menopausal hormones with combined estrogen and progesterone increases the risk, as we kind of just talked about. Obesity increases the risk. It's due to high estrogen contents in fat, and so that therefore will increase your risk of breast cancer. Women who get regular exercise compared to women who are inactive may have a lower risk by 10%. And there's no conclusive evidence that diet influences breast cancer. There's so many stories out there that not to drink soy or not to do this or that, but it's really inconclusive at this point, and it just is quite an area of research still. So we don't like to comment on that too much because you talk to one doctor and he'll say one thing, and you talk to another and they'll say something else. Numerous studies have confirmed that alcohol consumption increases the risk of breast cancer in women, about 7 to 12%. The American Cancer Society researchers found that current smokers had a 12% higher risk of breast cancer versus women who've never smoked. And the recent use of oral contraceptives may increase the risk of breast cancer by 10 to 30%. And back in the old days, the 70s and the 80s, all these hormone pills, the birth controls, had very high doses of estrogen. They've learned over the years that you don't need those high dosages to be effective. So this is more related to the contraceptives from years ago. So screening. So this is what's important for y'all to do, the women and the men with their family members, their wives, their children, their mothers. Clinical breast exams. For average risk women in their 20s to 30s, is recommended to be done every 3 years. For women over 40, an annual clinical breast exam should be done annually. Mammograms are low-dose X-rays, and what women have had a mammogram? Yeah, it can be a little bit uncomfortable, but I tell you, again, it can be a lifesaver too. So it's important to follow the recommendations, and again, beginning at 40 years old. So women at high risk should talk to their physicians for their screening recommendations. There's also called breast ultrasounds that are sometimes used to evaluate abnormal findings, and it's just like an ultrasound that would be done on a pregnant woman. And MRIs are used frequently too, and this uses magnetic fields instead of x-rays to produce a very detailed cross-sectional image of the body, and the physician would have to be recommending this. So these are pictures of mammograms. As you can see here on the right, or your left, excuse me, that's a normal mammogram. And you can see it looks nice and clear. You can see the ducts and the lobules. Everything is looking good here. In the middle, this is a benign cyst, and it's almost egg-shaped, and it's very round, very well-defined. And the cancerous tumor on the right, you can see it's very irregular, the borders. It just doesn't look right. So this, indeed, is cancer. So once a woman is done, yes? Sure. Yeah, what they do sometimes, it's called a fine needle aspiration. If they find a cyst and it just is bothersome, it won't go away. And it's just they insert a needle, they aspirate it, take the fluid out, and then they just monitor that. So, so you're a woman, you've just been told that you have breast cancer. That can be quite overwhelming. So if you're like me, sometimes if you're in the doctor's office and they're talking to you, it's just half of what they're telling you is just flying over your head. And that's part of my role where I come in. I try to help guide the women, educate them, let them know what their next step is. So if a woman is just newly diagnosed, what they can expect is to be referred to a surgeon, because the surgeon's role is to get the tumor out. They can expect to be, at some point, referred to a medical oncologist. They're the doctors that will be looking at the pathology and treating it more in a systemic approach, making sure that the patient after the surgery is not producing any hormones where they can provide anti-hormone medication. They'll be referred possibly to a radiation oncologist where they would have localized treatment to the tumor area. Also a plastic surgeon, depending on what the woman has decided to do. They could, if they have a mastectomy, they have the option to have plastic surgery. So the different types of surgeries are a lumpectomy and a mastectomy. A lumpectomy removes just the tumor and a small margin of the tissue. And more often than not, if a woman has a lumpectomy, the doctor will also remove a lymph node to make sure that it hasn't spread to the arm area. A mastectomy, there's several different kinds, and it's changed over the years. They used to do just radical mastectomies where the women were just severely disfigured, but they're not doing that anymore. They realize that they have just as good outcomes with doing simple mastectomies or just less radical procedures. So they have the option, if a woman does decide to do a mastectomy, you can do reconstruction along with the general surgery, or you can do a mastectomy with reconstruction post-surgery. So if you do it during general surgery, this includes the patient selection of their mastectomy and the reconstruction with the plastic surgeon. So this is just an example of this woman. As you can see, she had a mastectomy. The entire breast was removed. You can see the scar. I'm always amazed when I see the outcomes of these women, how beautiful the outcomes are. This is the post-surgery, obviously. So she chose to have her mastectomy and then have the reconstruction after the mastectomy was done. It's getting louder. Whoops, let's go back a little bit more. You see here, the whole nipple, areola, everything was removed. And this is just so beautiful. I'm just always amazed. The areola is tattooed. And the nipple is, they take a skin from another part of the body, they wrap it, and so she's got a new nipple, and they match just beautifully. I'm a little upset with her about this, the sunburn, but but I mean, she even got a little breast lift to go with it. So the outcome was really beautiful for her, and she was very pleased. They also can take what's called the gluteal flap, where women that they prefer not to have the implants because they feel they're too cold or they want their own tissue, where they take the skin, fat, and muscle from the gluteus, and they remove it and shift it over to the breast. So an incision is made at almost like a football shape, and they'll take it, they'll transplant it, but this is microsurgery where they take arteries and veins, and it's a very intricate type of surgery. But the outcome is really terrific. Women, they've got their own skin, it's warm to touch. You can have an implant put underneath this if they want it a little bit larger, so that's a nice option. This is called the latissimus dorsi flap, where they're able to take the flap that they call here. It's the skin, fat, and muscle, and they tunnel it underneath the arm and up into the breast. So this way, the arteries and veins aren't cut, so it's just removed and placed like this. She could come for phase 2 of the surgery after this. You notice how when the flap is done, where she can have the areola and the nipple placed at a second surgery, or third, or phase 3. And this is one of my favorite. This is called the deep inferior epigastric perforator. And this is where the woman gets a little tummy tuck along with new breasts. This is a very intricate, long surgery. It can take 8, 10, 12 hours, depending on how successful they are, because it's vascular surgery again. But we have some of the most fabulous surgeons in this town with PRMA, plastic surgeons that do these, and people come from all over the world to San Antonio to have this type of procedure done here. So we're very fortunate. So a woman has had a lumpectomy, meaning they've only taken just a part of the breast. So the next goal is to kill any remaining cancerous cells in the breast to prevent recurrence. So they've got the cancer out, now they don't want it to recur. So this is sort of like an insurance policy with a lumpectomy, where you go in and the radiation is very targeted to the area where the cancer was found, and they go in from anywhere from 5 to 30, 35 treatments. So this is typically done with a lumpectomy. Chemotherapy, we've all heard of this. The goal is to prevent a recurrence of cancer by killing any undetected microscopic cells that may be lingering somewhere else in the body. It involves a medical oncologist, and the treatment plan will be discussed with the patient based on the cancer cell type and the size of the tumor, if it was in situ, meaning if it was in place, or if it was an invasive cancer, growth rate, many factors that will determine what the plan is with the medical oncologist. And they have what's called adjuvant therapy and neoadjuvant therapy. Adjuvant would be chemotherapy post-surgery. Neoadjuvant would be chemotherapy pre-surgery. And you would have the neoadjuvant, it's because maybe the tumor was too big or too close to the skin, and they want to shrink that tumor prior to having surgery. And chemotherapy, it's a chemical treatment where drugs are infused through an IV into the bloodstream in a systemic manner. Typically, a Metaport, it looks like a little pacemaker, is placed underneath the chest wall, and it's inserted for this treatment. So there's a wide variety of chemotherapies, and we all hear it. It's almost like a 4-letter word, and a lot of side effects. But to tell you the truth, over the years, our physicians have gotten very smart. They try to be very proactive. They know that the chemotherapy is attacking our rapidly growing cells, which are cancer cells. But we also have other rapidly growing cells in our body, anywhere from our mouth all the way to the anus. So you can have mouth sores. You have your hair cells are rapidly growing, so your hair is affected. You can have GI upset, nausea, vomiting, diarrhea. So doctors will prescribe antiemetics, which for nausea, they want to get you hydration, and they try to make it as easy as possible for you. So we're getting better and better with dealing with the symptoms with chemotherapy. Hormone therapy. So going back to when the surgery was done, the tumor was taken out, the pathologist is going to look and see what was causing these cells to grow. And the majority of the cells grow because of hormones, estrogen and progesterone. So what they have now is called medication, tamoxifen is the name of it, where it can block the receptors on these cells that like hormones and prevent them from growing for the future to prevent recurrence of cancer. So again, another insurance policy. So for women that are estrogen and progesterone positive, meaning their cancer cells like that, feed on those, they can take that pill for anywhere 5 to 10 years to block those receptors. Ovarian ablation, premenopausal women with hormone-sensitive tumors may benefit from the removal or suppression of the ovaries, and that's called an oophorectomy. And I know this was Angelina Jolie, that's her next step. She's going to have her oophorectomy. And then there's aromatase inhibitors, and these are for postmenopausal women. It just has pretty much the same effect, but that's to reduce the risk of recurrence. And then we have what's called targeted therapy that blocks proteins that cause cancer cells to grow. And approximately 15 to 25% of breast cancer overproduce the hormone. It's a growth-promoting hormone called HER2. This gets a little bit more complicated, but anyway, so there is medication to block this also. And prevention and detection. So the survival rate of breast cancer is increasing tremendously over the years due to improved self-awareness, early screening, improved diagnostics, and treatment plans. However, it remains an important health problem, and early detection continues to be vital to improve survival statistics. Self-breast exams and lifestyle modifications are strategies you can use each day to reduce your risk. This is one of my beautiful patients. She went through so much. She did double mastectomy, she did implants, she did chemotherapy, and she's a survivor today, so very proud of her.